This week on the Back Table Podcast. This is a great point you emphasized right here. So if you had somebody that had multifocal tumors, we don't necessarily have to treat with one dose to the lobe, right? You can select them out and do multiple rad-sec.
So I am of the mantra that the way to really save the background liver is to get selective, right? So if there is, and I do this for HCC, and I don't mean to, I know this is an HCC session, but metastatic disease. So if I can get selective to multiple tumors, I would rather do that and give several doses than just giving a low bar dose.
I'm exactly the same way. I like being able to highlight that, and you brought up a good point. Welcome to Back Table Tumor Board, your source for the latest on multidisciplinary cancer care. I'm Tyler Sandow, one of the interventional radiologists at Ochsner Health. I get to help moderate this with my buddy Sabeen Dhand. We're going to talk about dosimetry today and our struggles through dosimetry. We brought in the experts. You have to my left, Zach Berman from UCSD. To my right, Kirema Garcia-Reyes from Mount Sinai. And to her right, Siddharth Padia, who needs no introduction, Mr. Legacy himself. I like to start with icebreakers because I'm a little tense when we come into these things. You'll see me talk with my hands a lot, and I apologize for that. If you can help me here, if you had one entrance theme song into the IR suite, what would it be? Don't lead off. Or no,
I got it. I got it. You know, mine's going to be Will Smith Summertime because that's just my vibe all the time. So that's my entrance theme for any case.
Well, given that it's baseball season, I'd say my walkout song was Song 2 by Blur.
Ooh, I like that one. That's a good one.
We went to an Iron Maiden concert last week, a few of us, so I'm going to go with Run to the Hills by Iron Maiden.
Oh, yeah.
And I would have to go with this song, probably none of you know, but it's a Puerto Rican singer, Don Omar. It's called Danza Kuduro. It's a great entrance song. You should all look it up and sing it and walk into it.
Mine would be Inner Sandman, only because Sandow, Sandman. That I would want, though it is a little bring it down.
Yeah, I just want to say, I'm surrounded by these very smart people here knowing dosimetry. I'm here to bring it down a notch for us community physicians to really understand dosimetry from, a basic standpoint. So I'm going to keep you guys in check over here.
But I'm going to counteract. I don't think it should be different whether you're in private practice, community, academics, transplant center, non-transplant center. I think it should be, relatively similar. And my guess is I practice very similar to you.
Okay.
This is a good start. When you finished fellowship, how much dosimetry knowledge did you have?
I think I can start with that one. So first of all, a lot of the really newer data has come out right in the last decade, pretty recent in like the 2020s. So I think when we graduated fellowship, in terms of actual thresholds, it was a little different. But in terms of the practicality of dosing, the first time I had to dose a patient myself in terms of the nitty gritty and how to do it. And I really didn't feel that prepared. Fortunately, I had a lot of mentors to go back to, but I wish that I'm trying to do it now with my trainees. I'm actually trying to talk a lot more. We're busy, right? So we're mapping, we're treating, but sit and just say, listen, this is the volume I'm seeing, this is the dose I want to hit, and this is actually the vial I'm going to order. So I think I'm trying to purposefully do a little bit more with my trainees because I personally didn't really feel prepared when I started as an attending.
When did you finish fellowship?
2020.
Okay, so I finished in 2009. In 2009, there was no concept of dosimetry, and I trained at Northwestern, which is largely kind of spearheaded radioembolization, and we basically did everybody the same, 120 gray, single compartment, and especially as a trainee, you don't know any better, you don't know any different. That was before we were starting to do radiation segmentectomy when I was a fellow, so we had no idea at that time, and you can clearly see the evolution that's happened over the 14, 15 years since.
Absolutely. 6 years after that, when I graduated from Northwestern, I had no idea how to do dosimetry because it wasn't part of our, training. We'd be there as get access, get into the vessel, then, have the delivery of this GBQ vial that came out of nowhere. So I knew nothing coming out of fellowship as far as dosimetry specific, calculations, what to go for, and I learned a lot of that on my own and asking mentors and people like you.
And I think part of it is that, in fellowship, you're learning, it's not like you're just learning about radioembolization. Yeah. That's one of 25 things you have to learn, right? So you have to learn everything else. And so are you really going to spend a lot of your capital learning about dosimetry, and you may end up in a practice where you're not doing any liver-directed therapy, right? So then, you have to kind of weigh the importance of it while you're in training. And so I think for most of us, you end up learning it afterwards.
Yeah, you got to figure out how to do the procedure before you can make the dosimetry part. Yeah. I was a lot like you, Kirema. I knew conceptually how it worked, but you give me a patient and say, figure this out. I was like, I'm screwed.
And I'm sure you could do the mapping, you would do your cone beam CTs, the procedure, you got it. But when it came to actually the dose and dosing, you're,
And it gets even more confusing because the different Y-90 products have different dosing, different thresholds, different targets, which makes an added
another
complexity.
Challenge. Now,
in addition to that too, it's just, there's not just one option too, as far as like, what do you dose? What's the threshold? You can go higher. There's just so many options to do that then, you don't know what to do in the beginning. And then I think now we're getting into this era of a lot more guidance of dose and everything. So.
And I think that's a very important point. It's still evolving and evolving a lot. So I'm sure we'll get into that. But
so I wanted to do this so that if let's say you just finished fellowship, you would be able to listen to this and you kind of get some guidance on how to dose. I think that, to me, it would solve a lot of the problems that I would have gotten had I been able to had the same opportunity. Zach, you gave a physics talk for Jess recently, and you talked about Y-90. Can you just hit it real fast? How does Y-90 work?
I think the easiest place to start is what Y-90 doesn't do. And for me, I don't think of it all as like ischemic embolization like you would at TACE. It's conceptually a very different procedure. If we could go back in time, maybe we would call it transarterial brachytherapy. The idea of taking tiny little seeds with radiation and putting it homogeneously throughout a distribution to slowly emit radiation. The radiation is going to either interact with water molecules to eventually cause free radicals to cause DNA damage, or at high enough doses directly with the DNA itself. And then we can talk about your treatment intent, because that's going to very much change how you want to dose it, because you're going for different mechanisms of cellular death, depending on whether you're doing a palliative or an ablative intention.
Okay, so that was cloud level knowledge, breaking down water molecules. All right, so you hit on this, where target dosing is important, right? So what do you guys think? Are you looking at, when you're looking at dosing, and before we talk about the simplest way to do dosing and the most complex way to do dosing, when you're talking about target dosing, you're looking at target dosing to perfuse territory, target dosing to tumor, target dosing to normal. What kind of strategies are you looking for there? What are your minimums? Do you have maximums? What do you think about when you're dosing?
So the best answer is it depends. And that's what makes it so hard, right? Because it's not a one size fits all. And I think we're going to go into it, but when you have a person who has a single 3 centimeter tumor versus the next guy who has a single 15 centimeter tumor versus the next guy who has 15 tumors evenly scattered throughout the liver, your goals and then your thresholds are all going to change. And so you have to start thinking about all your variables when you do this based on those are 3 of the more basic scenarios, right? So in one very quick example, a 3 centimeter tumor, you're not really worried about the normal liver anymore. In a patient with 15 tumors throughout the liver, you are very much worried about the normal liver. So then you have to kind of change how you're going to treat your thresholds.
Can I ask you a question real quick? So we'll talk about the 3 centimeter tumor. You're not really worried about the liver. So are you dosing to the perfused territory?
Yeah.
And what kind of dosing are we looking at with you? Like what kind of dose are you looking at treating with? What kind of activity are you ordering?
So if you're talking about a scenario, let's say you have a 3 centimeter tumor, you do a mapping angiogram, you're able to do what's called a radiation segmentectomy, which there are different definitions of a radiation segmentectomy, but in general, I think most of us agree that it's like equivalent to 1 Queenot segment or less, right? Some of the original definitions were a little bit more broad. Let's give another example. The patient is Child-Pugh A, okay? We're typically looking at a dose of the entire perfused volume of 400 gray or higher. And that was based on some of our explant data done about 3 to 4 years ago, where once you hit 400, your rate of complete path necrosis approaches 100%. So then the question becomes, well, is 500 better than 400? Is 600 better than 500? How high? What about 10,000?
That's
right?
the options. You have options, and where do you pick?
To be honest, we don't know. We have no idea. We never really did that kind of dose escalation work. Anecdotally, in my own practice, I'm probably shooting in the area of 600 to 800. Is that the right answer? I don't know, but that's just what we do. And we have not had any major downsides in terms of toxicities by going up to 600 to 800.
That's exactly what we do. And I would say, so I guess to say this, 400 is your minimum when you're talking RadSeg, right? What were you
And
gonna say,
I
Kirema?
think this is really important because I think they've both Zach and Sid have mentioned two really important things is, we're not talking your intent, right? Is your intent curative? We're doing a radiation segmentectomy. When you're thinking about radioembolization and, how, all the uses we have for it, curative intent is going to be to talk, even if I'm going to target to the perfused territory or I'm going to dose to the volume, to the tumor volume, we really have to think about that intent. We're not talking about patient selection in this specifically, but also Sid alluded to this, like which patient am I treating? So assuming you have appropriate patient selection, right? The patient has good liver function, good functional status, can tolerate the treatment. In this case, he's talking about a 3-centimeter tumor. You're going to get selective. It's going to be a radiation segmentectomy. I'm going to target to the perfused territory, and I'm probably going to target along, that's important, the minimum. So that threshold should be, we know that at least 400 gets us that complete pathologic necrosis, but we don't really know the ceiling. So I would say you at least have to target that. I tend to be just in the 600 range, just so I at least get 400. But so if you want to do a radiation segmentectomy for curative intent and you're getting really selective, then the rest of the liver that's not tumor there, it's pretty much expendable. So I tend to target those higher doses.
What are you worried about in the ceiling? So 2,000 gray to the area. What would you be worried that's going to happen?
I think two things. I mean, number one, is it necessary, right? Like, let's go to 10,000, 100,000. Like at some point, the tissue is going to be liquid, right? So you can't make it more liquid, right? Dead is dead. What have we seen? So we've seen, I think a lot of us who have done a good volume of this, once you do, let's say 1,000 patients, you start to see these very, very rare complications that happen in 1 in 500 or 1 in 1,000. So I'll give you a couple examples. We've seen a couple of fistulas where we've seen a fistula to the bowel in segments that were abutting, let's say, the stomach or the colon. How many times? We've seen this twice, and we've probably done over 1,000 radiation segmentectomies. So has it really changed our practice? Not necessarily. And in those cases, I would say the dose probably reached, in the ballpark of 1,000 gray or maybe even higher.
They weren't at Avastin, were they?
They were not. And we have had, and I think you and I talked about this a lot in the past, we have had 1 or 2 patients on Avastin. They did develop that. And it might be due to the Y-90, might be due to the Avastin, or both, or neither. Hard to say.
Or is it even related to the dose?
It might not be related to the dose. And because it's so rare, right,
Yeah.
it happens when you have an adverse event that happens in less than 1%, it's hard to make a root cause analysis, right? Because now if I say, okay, well, it's the dose, then I got to look at every patient that I treated, let's say with 1,000 gray, and I still find out that the vast, vast majority of them, 99% of them, did totally fine. So then should I really change what we do based on 1 in 1,000? And they eventually got better too. It wasn't, life-ending or anything like that. It's hard to make that justification.
Well, it's funny too. We talk about, I dose to make sure that I give a little bit of lung dose, have a little bit of lung dose left, right? When we're dosing at 2,000 gray, if you put in so much activity, you got to be careful that you save some lung dose for the future, right? Because these patients inevitably, you can't, if surgical resection, if the likelihood of recurrence after surgical resection is somewhere between 50 and 70%, if we're doing something comparable to that, the likelihood of a new HCC popping up is not negligible. So I think saving lung dose is important. But we talked about perfused territory dosing, and this is a good opportunity to swing back to Zach, because ironically, somebody at this table recently published something looking at actual dose to tumor and what the appropriate dose to tumor was. How do you look at this, Zach?
So it's I guess a philosophy, right? So when we talk about radiation segmentectomy, that whole concept came out of trying to mimic a surgeon going in there and taking a segment out. And so what that is, at least in my mind, is complete pathologic necrosis, right? Yeah. So instead of, it's still being in there and being complete pathologic necrosis, they just take it out, it's in a bucket, it's dead, right? So we're trying to mimic that. And so the goal with all this dose escalation, right, is to get every single tumor cell dead that we're treating. Legacy was great because I think it, to some degree, started changing our thought process about it, where, before it was dosing to disease control or dosing to response rate, imaging response rate, where Legacy said, 400 gray, which was a subpaper of Legacy from the resection patients, was just those who had CPN, right, complete pathologic necrosis. And so if we look at Legacy, it was 2 centimeter tumors with a, relatively more or less 2 centimeter tumors in a perfused volume, right? So maybe 400 gray was enough for that. But as the tumors get bigger, you probably need more radiation. And I think most of us have realized that, and that's why we've gone up to 600 or 800 gray to the perfused volume, because we realize that's a better target for that. And so I think the ultimate answer to your question of when do we stop dose escalating is when we have firm numbers for what actually gets us complete pathologic necrosis. And then we can, work backwards and say, do we need a multi-compartmental model to do that? Or can we still do single compartment, just knowing that for bigger tumors, they need 600, 800 gray to the perfused volume? But I think starting to think about it in the surgical mindset of we need to get complete pathologic necrosis is going to help us, answer that.
Okay.
Well, you mentioned something kind of interesting where you're comparing a 3 centimeter tumor to a 7 centimeter tumor, and 400 gray might not be enough. So, what's your calculation? What are you going to do for that 10 centimeter tumor? Are you going to give 1200 gray?
So let's start with something less crazy, right?
Yeah.
And work our way up to the 10 centimeter tumor, right?
Sure.
Let's say single segment, you do a mapping procedure. There's one segment going to segment 5.
Sure.
And there's a 4 centimeter tumor in there, right? So let's say it's a sphere, and the volume of a sphere is 4/3 pi r cubed, right? And so if it's a 2 centimeter tumor versus a 4 centimeter tumor, it's 2 to the power of 3, so it's 8. Never do math, right?
Yeah.
Live, but it's 8 times the volume, right? So
Sure.
even though you're saying it's only 2 to 4
It's
centimeters,
8 times.
it's 8 times the amount of tumor, right?
Yeah.
And so you may need to have much more dose. And so we found, at least in our study, and I think this is a start, I don't want to say it's the end all be all, but you need to get up to 700 gray to the actual tumor. Maybe not necessarily the segment, but the tumor. And you can start playing around with the numbers to see what sort of radiation dose will need you to get to 700 gray to the tumor, and that'll kind of help guide that discussion. So if you have a 4 or 5 centimeter tumor, you're going to be up in the 700-800 gray range. But for a 2 centimeter tumor, pretty much anything you do is going to be 700 gray-ish.
But that wasn't
to the tumor.
That wasn't just 700 gray to the tumor, it was 700 gray to the coldest area of the tumor, right?
Correct.
And so I think we're going to talk about voxel-based dosimetry in a second. But before we dive down that road, which I think is going to take us on a roller coaster, I want to see how you guys would dose this. I think let's apply that simple rad-seg dosimetry concept. We have a 60-year-old hep C and alcoholic cirrhotic, 3.9 centimeter mass in segment 5. I assume most of you would approach this as a rad-seg, correct? Correct. This was the mapping, and here's my run. It had a single feeder. I know our reflux there, so you're going to have to, ignore the reflux, but single feeder. If my perfused volume is right around 215 mLs, how would you dose this? Where would you dose where you are now? Child PUA patient.
Well, you already, so
I showed you what I did, but
Yeah,
tell me
you
what
showed
you
me
would
what
do.
you-
You can be
so-
critical.
600 to 800 gray, 484 gray is totally fine with me. And then, your variable is, okay, how much dose, but then what's your particle load, right? So that's your other variable that you can be. In our practice, this would be most likely a glass Y-90, which we would probably pick first week, Thursday or Friday. So most likely, again, I can't do the math in my head, it's probably going to end up being a 5 or 7 GBQ vial.
And I think the more of these you do, you start to get a gestalt, right? Because you said 5 or 7. That's exactly what I'm feeling. This feels like a 5 GBQ
And that's only,
vial to me.
and not because it has nothing to do, I'm not smart. I just did this 1,000 times. And so it's just pattern recognition, right, at this point. And so we know that I've had similar patient like this 100 times over, and I know like a 5 or 7 worked for me.
So a couple of things I think are worth mentioning. I agree with the approach completely, but you have a single feeder, right? So we didn't see your cone beam. I'm assuming you did a cone beam CT to assure you had complete, although it looks like you did.
Of course I did. I always do
No,
it.
but I want to, we talked about that person just coming out of fellowship, right?
Yep.
So remember,
Yes,
single
thank you.
feeder, cone beam
Please.
CT, you confirm, and I agree. I would target that 600 range, probably a 5 GBQ vial. I tend to dose first week Fridays with glass. I think it's an ideal day for dosing, but it's also the day I have the room. So it's kind of a lot of it is going to be also, when are you going to get that room time? So I would have approached this single vial 5 dBq radiation segmentectomy with a target dose of at least that threshold of 400, but usually in the 600.
And to play devil's advocate, let's say I wasn't using glass. Let's say I was using resin for this case. And as a rule of thumb, just because, as you said, you do enough of these, you get a gestalt for it, I just divide everything by 2 for your targets for glass and resin. And I think it has to do with the differences in the properties, the number of spheres, radiation per sphere, et cetera. There are some trials coming out that will help guide it, whether you need to do tumor dosing specifically with resin or if you can do single compartment. But, I think dividing by 2, so 250 gray MERD would not be unreasonable with resin.
So just out of curiosity, where did you come up with that? Just based on your own experience?
Yeah, exactly. And the prospective evidence we have, there's a single arm study that looked at dose to tumor with resin microspheres, and they showed a huge increase in survival and disease control, getting above 250 gray to the tumor, greater than 330 gray to the tumor if you can. And the more of these that you do, you start to realize that that's kind of like the MERD target you get into with that range.
I can ask you a quick question. So you're going to order a resin vial. What kind of resin vial would you order? Would it be Flex 3, Flex 5?
Yeah, so for single artery like this, you want to have as few spheres as you can. Obviously that's a moving target as well as more and more get onto the market. But Flex 3, Flex 4, I think would be.
You would try to use hotter spheres, as few number of them as I can. As someone who's hung their hat on this hotter spheres thing for quite some time, I was just trying to get my hotter spheres plug out there.
I think the challenge though with coming out with these dose thresholds for resin is that we're basing at least the 400 gray threshold on RadPath, and not only just on RadPath, but on getting a complete response at 4 years, 5 years, 6 years. And we don't have that for resin, right? So most of the papers looking at radiation segmentectomy for resin are looking at 3 months, maybe 6 months. And so there's still a lot of work to be done because I don't care what the 3-month results are. It's irrelevant at 3 months, right? We're not trying to tell patients that, okay, we're treating you in November and in January you're going to have a CR. Like, that's useless because you can do that with a bland embolization. What we want to say is that we're treating you in November 2024 and in 2027, it's still going to be dead. So I'm hoping that there is data that comes out to show this prolonged response with whatever dose thresholds they use for resin, because right now it's not there.
So that single arm trial I mentioned last month, they actually released the longer term follow-up at 30 months. And so we have 30-month data now. So it's not quite the 5
Still
years
not 5
you're looking
years.
for.
Still not 5
But it's
years.
not 6 months.
Yeah.
That's 6 months.
Well,
Okay,
yeah.
fair enough.
They're working on it.
I think it's important to really understand the impact of legacy. Legacy wasn't just about 400 equals CPN, which we got that from the side paper, but what was important, what put legacy on the BCLC map was the durability of the response. It was that 5 year. And I like to highlight that every time we talk about legacy, and I make sure that because CPN is great, and that was in that subset, but it was the durability of response, which also probably does equate to CPN to some degree because nothing's coming back at 5 years. We could likely assume it's dead. But I think that shows the impact of how you guys did. And you also were publishing legacy data. You were talking about patients that you were treating in 2014 and 2017.
Yeah. So it's 10 years.
Yes, this is a decade ago. Y'all were pushing the envelope, pushing the bar for us to be able to rise to where we are now.
The other thing to keep in mind, Tyler, is that, that with that duration of response and that the legacy paper had a lot of explants, we are now starting to move into an era of when we talk, the explants were done from transplants. We're starting to move to an era of maybe these patients don't even need a transplant anymore. And so at UCLA, we are in talks of changing our selection criteria. A patient like this, if they get a radiation segmentectomy or a successful thermal ablation, will likely no longer be listed for a liver transplant because this is considered on the same level as surgical resection. So now what's important for us as treating physicians, it's exactly what you referred to, that durability of response, right? We want to try to get this patient a permanent, complete, forever kill of that tumor because they may never get a liver transplant now with the supply and demand issues that there are with organs.
I just had to second in the community. I mean, that's what happens most of the time. These patients are not going for liver transplant. They need the durability of a treatment. And frankly, they don't want a liver transplant, so.
Well, that's why we changed our strategy. We were TACE heavy up until about 2018, and obviously transplant allocation changed. So our access to livers, we went from being number one in liver transplant for a decade and making it on an episode of The Simpsons, Oshner. But obviously patients were not getting livers like they used to, and so we needed a more durable response. So we switched, and we see the same kind of stuff that was produced in Legacy by switching over. And that was, interestingly, I heard Riyadh just say this, that Y-90 has replaced TACE as the primary bridging strategy for transplant patients.
In the United States.
In the U.S., yeah. Okay, so we're talking about simple rad-seg. We talked about threshold dosing and then dose optimization, and we'll get back on voxel-based dosimetry. But before that, y'all alluded to this, dosing to normal. What are your target strategies when you dose to normal? Like maybe you're doing a palliative approach, right? We're not going curative intent anymore. What are your thought processes in dose to normal?
Well, and you said we're not going curative, but that's really going to depend on, again, what my intent is, because there's also if we're doing a modified radiation lobectomy to, bridge somebody who doesn't have enough FLR, the way I'm probably similar, but in that case, I'm usually doing an ablative dose to the tumor, right? And then I'm doing at least trying to dose to 100 to the normal, right? Because I'm trying to get that hypertrophy on the other side. We've seen on data that as long as you're getting above 88, that's it. When I'm treating multifocal tumor, let's say unilobar multifocal tumor, I'm still, honestly, the way radioembolization has evolved, I'm still mostly thinking in a rad-seg way, right? So if I can get selective to treat 3 tumors, then I will do that. But if we're actually going, if I can't even remember the last time I just did a single low-bar dose to treat multiple tumors instead of getting selective. But in that case, that's when you're actually thinking about that dose to normal. And usually I like to keep it around that range.
So this is a great point you emphasized right here. So if you had somebody that had multifocal tumors, we don't necessarily have to treat with one dose to the lobe, right? You can select them out and do multiple rad-seg.
So I am of the mantra that the way to really save the background liver is to get selective, right? So if there is, and I do this for HCC, and I don't mean to, I know this is an HCC session, but metastatic disease. So if I can get selective to multiple tumors, I would rather do that and give several doses than just giving a low bar dose.
I'm exactly the same way. I like being able to highlight that. And you brought up a good point that I totally passed over.
What if you can get selective to some tumors, but then some you can't? They're more central. Then does that change? Do you do a low bar dose then, or do you do the boost dosing where
I might again, I'll always try to get if there's a way to get selective, I'll get selective to those. In that case, I might maybe stage. But honestly, by low bar diffuse HCC at our institution, we'll probably go to systemic first, right? So the days where I'm just giving a low bar dose just because, I'm always modifying my lobectomy usually. Either, double segmental approach or doing an ablative dose to the segment followed by just a lower dose to the rest of the liver.
I agree completely with everything you said. And I have a very similar philosophy with how I treat. But for the people out there coming out of fellowship, it's very smart people, one sitting across from me. And then also similarly for resin microspheres as well, develop dosing guidelines. There's journal articles you can go to that have extensive, and they have every single scenario, right? And so one of the scenarios is what you mentioned, palliative dosing, not ablative dosing, what targets do you hit? I believe in the most recent guidelines, and if you can correct me, I think it was background liver dose of 80 gray with glass, and then 40 gray is what the resin target is. So below 40, again, the 2-to-1 ratio popping up again.
Getting at least 205 to tumor. So you want to think about
Correct.
That tumor dose,
yep,
yeah.
Right, but yeah, exactly. So I recommend for everybody out there who's wanting to get more advanced with their dosimetry, go to those guideline papers, right? Because people put a lot of thought and effort into creating those, and that's always a great place to start.
And they're actually really straightforward. Like there are scenarios, they have low bar, it's actually really great.
It really does, and I think that's
simplified.
We hit that, and that's we always. Yeah, I think if you follow guidelines, you have footholds to stand on whenever you're justifying your approach. I think it's hard to challenge somebody that's following guidelines with the way that they treat. So dose to normal, we'll say for glass right around 80. For resin, we'll say right around 40. And you talked about this, that when you're trying to do rad lobe to hypertrophy of the contralateral lobe, rad lobectomy to hypertrophy of the contralateral lobe, you're targeting what kind of dose to normal?
100. At least over 88 is what the data has shown, but I personally target 100. And I think that's what the guidelines in those papers say as well.
Okay. So I think this is a good opportunity to show another case, and I would love to get your take on this. Here we go. So I would call this my super challenging case. And this is a recent one. Child PUA, no significant cirrhosis, biopsy-proven HCC. He's got multifocal tumors. He's got a pretty good distribution of tumor throughout his liver. All right? At your institution, how would you tackle this case? I'll tell you what we did, and it was not exactly the way that you would have thought it would have gone. And so how would you have tackled this?
So in our place, the first discussion comes whether they get liver-directed therapy or a clinical trial or systemic therapy. In all likelihood, being at an academic institution, there's a strong likelihood this patient would get a clinical trial. But let's say clinical trial is not available and they're getting liver-directed therapy for the sake of discussion. We would probably start with the radioembolization, and by meaning start with the radioembolization, you do the mapping, and then you make the decision after the mapping, right? So I don't make a decision as to how I'm going to treat until we do a mapping angiogram and see which out of these that we can select and isolate, similar to what Kirema was referring to 5 minutes ago about trying to isolate tumors, even if you have to do it sequentially, because that's been our approach as well, instead of just doing a shotgun whole liver approach here, which I don't think is probably the best idea.
Sid, what about systemic for this patient? Is that something you would consider at your institution?
So let's say they weren't on a clinical trial and we decide to do liver-directed therapy. I think there's two scenarios. You either do liver-directed therapy and then you combine it with systemic right away, or you do the liver-directed therapy and then you assess for the response, and then you might decide to do systemic therapy later if you want to. We've kind of taken that approach, a much more conservative approach, knowing the fact that systemic therapy, while has made major breakthroughs in the last 4 years, still has a lot of baggage. There's still a significant rate of significant adverse events. It is very expensive. It is very involved for patients in that they have to get infusions at an infusion center every few weeks. So if they don't need it, why should you offer it to them, right? So now our approach has been, you do the liver-directed therapy, you do a scan in 2-3 months. If there's viable disease, then you can consider systemic therapy.
Based on this images I'm seeing here, I mean, liver-directed therapy, there's going to be a ton of vessels feeding all of these tumors here. 100%. So, I mean, basically every single branch of the hepatic artery. And so it kind of comes back to my question, like, if you can just get the bigger tumor there, what is your response to liver-directed therapy with all the other lesions?
Why can't we get the smaller tumors?
Just all of them?
Yeah.
Sequentially.
Well, then we can do
not all at one sitting. Yeah, sequentially.
I think you highlighted an important thing. And
we don't have... Oh, go ahead. Good.
I was going to say, Juan Jimenez, I watch him talk on this all the time, and he says it perfectly. He's like, and you said this too just now, Sid, the mapping is part of my diagnostic workup. Like, I'm not making a treatment decision until I do a mapping.
Correct.
But I will tell you, so this patient went on a clinical trial, and the AFP went from 8.4 to 11.2, but relatively stable disease, but no significant treatment response. And the patient's well-informed, has an incredible oncologist, and the oncologist was like, hey, we're not making many strides. And when we first talked about this patient, they asked us to biopsy this because there was no evidence of cirrhosis. So we biopsied it, we knew it was HCC, and our thought was, let's give Y-90 a shot to start. Child PUA clinical trial made a lot of sense. Went on a clinical trial, no significant response, didn't want to sit here and let things just grow. So let's do something a little more definitive.
Did you target? So I'm looking at this, of course, mapping. So because I really don't do whole liver at the same time. So the other question is, what do I target first? Do I go for the right? I don't know what's feeding that segment for, but are we going to start with the side with dominant disease usually? So did you guys do this sequentially, or how did you?
Well, so here we go. Okay, so I'm interested in your opinions here. Zach, you haven't talked yet, so I want to get you. All right, so this is so a guy has a replaced right. So there we go, replaced right, multifocal feeders, right? A big tumor in the right, basically tumor in every branch of the left. I could play this again here. This was what the left looked like. Pause it there. And this is what the right looked like.
Yeah. So when I think about these types of cases, because we are in a somewhat data-free zone, right? If we wanted to look at quote unquote phase 3 data, I think it would be either LEAP 12 or Emerald 1. I don't think this would be a great combination, TACE plus immunotherapy. But I think, what's going to eventually cause issue is disease progression and hepatic decompensation with this amount, right?
Yes.
So I think, at least at our institution, there would likely be some form of systemic backbone, right? And for me as an interventionalist, having systemic therapy on board gives me time, right? Because I'm not worried about if I treat this big one coming off the right, the left side is just going to explode, hopefully, right? And so we would probably do some combination of systemic therapy plus local regional therapy. And so my goal here is to prevent worsening disease burden inside the liver, decompensation, and then, death. You have great targeting of all of these tumors, but particularly the replaced right, that huge tumor, you're going to get a really effective, dose to the tumor. And so I'd probably target that one first with some sort of systemic backbone to give me time so I don't have to start like stacking local regional therapies one after another quickly to prevent the other ones from progressing, and then taking our time and slowly going after the rest of them.
Now, you talked about,
There's something I love that I'm seeing here, what I'm thinking, and is how much of your contrast is going into tumor, right? So that when you're treating at least, and I agree, I would approach it really similar to Zach. I would start with that right side, but I know that when I pick a dose, I know it's mostly going to go to tumor, just based on this.
Okay.
So I love that.
So you talked
and
about
also,
this.
sorry, one more thing. Sorry, when you're thinking about biology, right? This is a patient that has already been on systemic, AFP's 8, and he hasn't really been progressing. So somewhere you're in a tumor biology, at least at this stage, that hasn't, this tumor, which is what we fear, right? When we are doing local regional, is are they going to progress quickly? But that test of time, right? So that it has proven that it's really not that aggressive at this stage. So I do think we have some time.
Well, you also talked about this, and I do want to highlight that. You said, well, you could get selective and do multiple rad segs if you could. So you can see those segment 4 branches. Those are isolated feeders to what were large tumors on the cross-sectional imaging. So my intent was we're going to go multi-compartment to segments 2 and 3. We're going to go multi-compartment to that replaced right, because obviously the tumor's taking up the majority of the dose. So, you give a dose there, and then we were going to rad seg the 2 tumors in segment 4. So that's how we did it. And I think there's many different ways to tackle it. We broke it up into 2 different treatment days, and this is how it looked. So rad seg 500 gray to that larger tumor up in segment 4, the smaller one, another rad seg, and then we multi-compartment to safety. We did 70 gray to normal on segments 2 and 3, but it wound up giving us tumor doses around 300 to 200. Remember, they were very hypervascular tumors. Brought him back a month later and did a multi-compartment lobar dose to the right hepatic, which got us 262 to tumor. And so and we did 130 gray. It was just a 130 gray to the perfused, 262 to tumor. So about a T to N of 2 to 1. All right, this is what it looks like. This is follow-up. And this is what I think is quite impressive. Look at how many black holes you have in the tumor. So a lot of those tumors have died, and you highlighted favorable tumor biology, right? One of the things to note here is that there still is some viable tumor in that right hepatic artery, or that right hepatic lobe tumor. And that's because that tumor was drinking like nobody's business. And so the bottom part of it drank, but the top part didn't. Here we go. So the top part was the furthest away from perfuse. So now you're here. What do you do next?
So first question is, what size vial did you pick for that right side?
For that right side, it was 27. It was it was 2 combined vials, so it was 27
20
GBQ.
plus a 20 plus a 7.
And so I did and it was because
First
I was
week or second week?
It was second week. So if I dose 120 or greater, or 120 to the 200 range, I'm a week 2 Monday, Tuesday person. If my rad segs though, majority of them are 500 or greater, and I'm a week 1 person. So I dose week 1 vials for rad set for high dose rad segs, and it's a similar sphere concentration if you think about it, because it's 3 days later. So if you dose in that 250 to 120 range, week 2 Monday, Tuesday tends to be the day that I choose, and it was a 27 GBQ vial, or 27 GBQ worth of activity.
Any new disease on this?
No. So everything, black holes, and then no new disease.
So if there's interest in, trying to get, 2 things. Number 1 month is early.
Yes.
Right? So one option is just to wait it out, right? Like his biology is not exploding with tumors. Just wait it out another 2-3 months, because especially larger tumors, you're not going to often see I would say the majority of time, you're not going to see a complete response at 1 month for an infiltrative 7-8 centimeter tumor. So that's one option. Your second option is to retreat. I personally would probably just wait it out since its biology has been stable. But let's say you wanted to retreat it, maybe just retreat that right hepatic tumor and just up your particle load.
Yeah.
Right? So whatever you use, you can use the same dose. Just double the number of particles, however you want to do the math, whether you want to use glass, you can you switch to resin and increase your particle load that way. So you can get more spatial coverage because, as you said, the bottom part was drinking all the particles.
I might remap this, the right side.
Okay.
Just to see, and we're not seeing every second, everything you did during the case, but I tend to do a surrogate 0.5/5 injection where I'm treating from. And sometimes when I do a cone beam with that, I can see, the tumor is mostly drinking it in the inferior part. So maybe I should select another vessel. So I would remap this and kind of try to figure out, is there some vessels I can get into to treat this versus, do I need to increase my particle load? And then I'll go to Zach in terms of how he would have treated this maybe with resin. But yeah, I would remap, and there you see, you're pretty much selecting the vessel that probably would take you to the rest of the viable tumor.
I think our goal here is also super important, right? So we have a trial, the rapid trial done out of MD Anderson, that showed that even at 3 months, the complete response rate was relatively low, but having done nothing between 3 and 6 months, at 6 months, the complete response rate goes higher. And they were larger tumors in that study. So waiting, even if you have viable disease, quote unquote, might be the right thing to do, right? Because you still continue to get response. And then the second question, we have is, what is our goal, right? If our goal is to somehow downstage this guy to transplant, makes sense. Go in there, you got to get this thing non-enhancing because that's what's going to get you on the list, right? Successfully downstage to be listed. However, if this guy's, ultimate goal is just disease control, I think you wait a little bit longer instead of just rushing and doing therapy because we're treating an image where he might, or she might be better off just waiting to see what our final result is at 3-6 months before making a determination whether to go back in. I think what you didn't show, which would have been really helpful for this tumor, was a SPECT afterwards or a PET.
Sure.
Because if you had complete coverage of the tumor and you still had some viability, okay, wait it out, right?
Exactly.
Right.
But if you got a SPECT and it only had it
only at the bottom
by the
part.
bottom,
Right.
Yeah.
much easier decision to come back in.
So I was assuming that that's what the spec looked like, but that's a great point.
I will tell you, there was definite heterogeneity in that tumor where it was, if you look back at the bottom, you knew that it was kind of all saturated down there. And it got some radiation got up there, obviously, but not as much. And you can see on that image on the left, right, the top part of the tumor is what's showing parenchymal enhancement and the bottom part's not. And that's kind of what we saw in the SPECT. And so my thought process was, everything's holding steady. Let's go back and remap and try to get past the feeders that were drinking everything and then go up. And that's what we did here.
But to cover a very important point, and I think this is going to become more important as we go, future in the future of dosimetry. You could have a high average tumor dose with this picture, right? Mm-hmm. You could have treated the bottom half and got 1,000 gray to it, but the median tumor dose might be 1,000 gray. But the coldest part of it, the top part of it, maybe only saw 20 gray, 30 gray or something like that, right? So as we start to figure out how we want to dose these, maybe looking at the entire tumor, particularly with these larger ones, to see what the dose to the coldest portion of the tumor is going to become a lot more important.
And this is what I wanted to talk about this too before we ran out of time, is voxel-based dosimetry, right? And you were talking about the coldest part of the tumor. Can you go through some of those key variables? What is that? What do you call the coldest part of the tumor?
Sure. So there's two different ways that we look at it, and these are both kind of terms we stole from radiation oncology, where you look at something called a dose volume histogram, which looks at the dose to different portions of the tumor based on each voxel that the tumor is in, right? So the D1, which is the dose to the hottest 1% of the tumor, could be a bajillion gray, right? Where your D99, which is the dose to the 99th coldest part of the tumor, could be 1 gray. And you're not going to have a complete response. Right. Even though, you got a bajillion gray to 1% of it, the coldest part didn't, right? And so as we go through different variables, D25, D50 being the dose to the, average or median, 50% of the tumor, we start to think about that. The inverse of that is something called V, like Victor, V whatever gray. So it's the volume of tumor that got exposed to a certain gray threshold. So V100 would be the percent of the tumor that got 100 gray of radiation. So V100 of 100% means the 100% of the tumor at a voxel level got 100 gray of radiation.
Right.
And so D100 and V100% are the same, right? And so we can use those interchangeably at that high numbers. But I think looking at D95, so the coldest 95th percentile of the tumor, is super important, particularly these big tumors, to better understand what your radiation doses are.
And you alluded to this too. Bigger tumors are heterogeneous, right? And so we know that there's going to be some areas that are going to take a lot, some areas are going to take less. And so your paper said your target dose to the D95, the coldest area of the tumor, should be 719 gray.
Something like that, yeah.
I remembered it.
Okay.
So it was, but I think that's important. We saw similar stuff. We recently looked at our own data and put out some stuff, and we saw similar outcomes. We didn't actually do all the fancy statistics that you did, but it's about upping the dose. So like 400 gray to the perfused territory is our new minimum to go for. But when we're talking about dose to tumor, we need that dose to tumor be dramatically higher, right? And so that's why that 600 to 800 that we were talking about when we first got into this, when we're talking about rad-seg, is critical, because especially for these larger tumors, and I don't think we appreciate it as much. These larger tumors are going to need hotter doses in the coldest areas. So we have to raise our dose to get that there. And that's why I think we see good results with 600 to 800 gray.
I have a question. How are you even determining the histogram? I mean, how are you determining the cold parts of the tumor?
Software has to do it, and it's based on either SPECT or PET, because it has to create a dose volume histogram, which is a lot easier to see visually. But it has to go through at a different voxel-based level based on your SPECT or your PET and actually calculate the dose.
Are you suggesting that, software should be used for most dosimetry?
For your 2 centimeter tumor, no, right? We have very good methods of doing it, 600, 800 gray, keep it easy, right? But I think it starts to break down a little bit once you have tumors that are pretty much your entire perfused segment, right? And so, I would talk to you and you would say, I would just give 800 gray instead, right?
I don't find the need for it.
It makes sense.
I don't find the need for the software, and that to me just results in me going home later from work. Like it doesn't, to me, it doesn't add
from
benefit.
a practical standpoint.
From a practical standpoint, if you can target 600 to 800 and, by cold and hot, a lot of it now becomes your particle load issue, right? If you're inserting a 3 GBQ vial, which is 750,000 particles in a 7 or 8 centimeter tumor, you're going to get some heterogeneous distribution. You're going to get cold spots. So how do you fix that? You don't increase the dose. You just increase your particle number, right, to get you a better spread.
But I guess
instead of going from 3 to 7 or 10.
Yeah, well, I think what Zach did, I think, not to get too far off, Zach and us, we don't do that. I don't use software to plan my dosing. I did it to justify why we saw things in the real world the way that we do, right? Like I don't have the time or the energy to go back and actually overlay all my spec CTs and make sure everything's registered right. But I do want to understand why I'm getting great results at 800 and I'm not necessarily seeing the same results that I would have expected for legacy at 400, right? If I did 400 to the perfused territory and I didn't get 100% CP, and maybe I was treating a larger tumor that had more heterogeneity. So I wanted to explain findings in the real world, which is why I went and looked at it. So now I dose at 600 to 800 gray to the perfused territory, which is practical. I'm not looking at dose to tumor. But I also think there's a point in time where you can only pack in so many spheres. I think it's a flow-dependent phenomenon. And I think that we're always going to see heterogeneity even when you pack in more spheres. And I think you see that in some of those resin papers that looked at the same thing. Their D95 was dramatically lower than their median perfused dose, similar to what we see with glass. And so we have to, at some degree, there's a balance between how hot your spheres need to be and then how many spheres you get, to your point.
But to answer your question way back when at the beginning of this, it's going to help us give us a cap for how high we need to go. We don't need to go to 2,000 gray. We don't need to go to 3,000 gray. And so it'll at least give us a better target of where, by experience, you're realizing we need to be at. But for someone who's out there saying we need 2,000 gray of radiation, you could say,
I don't think most people are advocating routinely going to 2,000 gray. When does these 2,000, 3,000 gray happen? It happens when you're ultra selective, your perfused volume is 20 cc's, and you're giving a 3 GBQ vial. You'll start to get 1,500 to 2,000 gray, depending on the day of the week, because as Kirema said, you're there in a certain day of the week, right? So because that's when you have your lab time. That's when we start seeing in practicality, when we start getting doses in the 2,000 to 3,000 gray. It's because that's just the volume.
But I guess my question is, why not dose
small.
everyone at 2,000 gray?
What we're doing works in 97 to 99% of the time, right? So I would rather focus our energy on fixing variables that need improving, which that doesn't seem to need a significant amount of improvement at this point.
Can I just say one more thing going back? Because we were talking about software versus not using software. I think there's definitely a role for it, but I think even, we've honestly been a little bit of later adopters of the software, but I still kind of, when I'm thinking of tumors like this, I'm still kind of thinking multi-compartment in my head, right? So I'm thinking, okay, so I see just from visualizing, just from my cone beam CT, the specs, so I can kind of get an idea of, okay, so this part's hotter, this part's colder, so how am I going to target this? Am I just going to give more particles, higher specific activity? Am I just going to try to split it into 2 vials or 3 vials to get whatever I want? So I think there's ways of doing this that's not necessarily understanding the concepts. Of course, it's not, as we won't get the dose volume histograms, but you can still really understand the tumor, the flow, and kind of try to at least target those thresholds without necessarily having the dosimetry.
Cool. I think this was a good session. Yeah. What I like is we all have similar approaches, but we're coming to the same conclusions with different approaches, right? We all have our core knowledge, our core foundations are all built on the same pillars, which is a lot of Mr. Legacy's doing.
I want this fancy software. This is this what I want.
Well, you're just going to have a lot more time to do it because it's not easy. I wanted to thank everybody for this opportunity. Getting the experts in the room to talk about it from multiple different perspectives is really cool, right? We have some fancy high-end technology. We have some practical approaches, and how do we all use it to get to the same thing? And I think we got some good answers here on how to do dosimetry. So thank you guys.
Thank you for having us.
Yeah, thanks, guys. I do think we need a part 2 because there's a lot more questions here on this paper that I wanted to ask.
I know, I so badly. I was dying to do part 2, but I think if I drug this over, they're going to pull me out.
I can open Pandora's box. Was my next question.
There's only so much dosimetry at a time.
I know. Well, I wish maybe we can convince Aaron to let us do a dosimetry part 2. I would love to play this game.
We'll do it for sure. Yeah. Thanks, guys.
Thank you.
Thank you. Thank you so much for joining us on Backtable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _backtable onc. That's _backtable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
and Josh Spencer.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Ann Dang.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
Thanks again for listening. See you next time.